Good morning, good afternoon, good evening. It's my distinct honor to welcome you all to the OHDSI Asia-Pacific Symposium 2020. I'm Patrick Ryan. I'm Vice President of Observational Health Data Analytics at Janssen R&D and Assistant Professor in the Department of Biomedical Informatics at Columbia University. But probably most importantly is I'm an OHDSI collaborator, just like all of you. And it's a real honor for me to be able to kick off this Asia-Pacific Symposium with all of you and to start this session with my colleagues, Christian Reich and George Hripcsak. We've got a great agenda for the next 2 days of tremendous opportunity for us to be collaborating together, both within the Asia-Pacific region, but also to learn globally and to think about how we can connect and collaborate globally. And so it's a tremendous honor for me, Christian, and George to be able to welcome you all to the OHDSI Asia-Pacific Symposium and to kick off this session with a high-level overview about what we're doing at OHDSI, why we need to be doing this together, how we're doing it by building an international data network, and some of the accomplishments we've had. And so George, Christian, and I will walk you through a high-level overview, and then we'll jump into the rest of the symposium. Before I start, I really want to thank and congratulate the OHDSI Asia-Pacific Steering Committee for putting together a remarkable agenda. And as all of you will see, a lot of hard work has gone into building this collaboration across the Asia-Pacific region, and it's a thrill for me to be able to be here with all of you participating in that. I also want to recognize and congratulate the great accomplishments that have already taken place across our various OHDSI regional chapters within the Asia-Pacific region. That includes our regional chapter in China, in Japan, in Korea, in Singapore, in Australia, and in Taiwan. And what's a tremendous accomplishment about putting this Asia-Pacific Symposium together is that despite all of the challenges and restrictions and the fact that we can't be together, we've been able to bring together all of these geographies, all of these countries, all of these organizations together into this virtual meeting to create something that I think is really going to move forward OHDSI's effort in the Asia-Pacific region, but also is going to be a bellwether for how we can collaborate together globally across the OHDSI community. So with that, let's get started. Some of you, amongst the over 400 of you who have registered and are joining us for this conference, are new to OHDSI and are here to learn a little bit more about the community. So Christian, George, and I will be kicking this off by providing a perspective of what exactly OHDSI is all about. And I'd like to start with a focus on what OHDSI is to me, which is all about being an open science community. OHDSI's mission is to improve health by empowering a community to collaboratively generate the evidence that promotes better health decisions and better care. And we're doing that by trying to adhere to a set of shared values across this broad international community. Those values include innovation, reproducibility, community, collaboration, openness, and beneficence. What we are trying to do is bring together data from the real-world experience of patients and to generate evidence that can actually be used to action and support decisions throughout the healthcare system. And it's this journey from patient-level data to reliable evidence that we're all on together. And what I'd like to motivate here is that this journey is something that none of us can actually do alone, but all of us can meaningfully contribute to. When we talk about the journey from data to evidence, it's important to recognize that evidence isn't just any number that you can produce from data, but our goal is to produce reliable evidence that is meaningful to inform health decisions. And we've been thinking a lot about what it takes to make evidence truly reliable. We've identified 6 desired attributes about evidence that I'd like to share to motivate your thinking and hopefully to encourage you to continue on this journey with us. For evidence to be reliable, it needs to be repeatable. That is, the same person asking the same question to the same data set, using the same analysis, should get the same identical result. Repeating a scientific experiment to generate the exact same result is fundamental to our ability to analyze data in a way that can have credibility, because we need to know that we could actually repeat and produce identical results. More broadly, reproducibility, though, means that not only does the researcher who asked a question and had data and have performed analysis that they can get the result, but that some other researcher could independently verify that a result could be reproduced. So any researcher should be able to take the same question with the same data and the same analysis and produce the same result. This basic tenet of reproducibility is fundamental to all of science. And yet when it comes to the analysis of real-world data to generate reliable evidence, many components of research that are out there fall short of this minimal standard. Now, we would also like reliable evidence to be replicable. That is, that given the same question, researchers could use similar data, perform an identical analysis, and generate similar results. It's that consistency of evidence when we can study similar populations that helps us build confidence and credence that not only are we performing a reproducible process, but that if that reproducible process were applied to similar data, that you'd get a similar result. We would like reliable evidence to be generalizable. That is to say that for the same question, if we apply the same analysis to a different data set representing a different population, we may still yield similar results. Generalizability is one of the things I'm particularly excited about being here for the OHDSI Asia-Pacific Symposium, because the healthcare experiences of patients in China, of patients in Japan, of patients in Australia, of patients in Korea may be different within a given country. But when we can learn fundamental phenomenon about diseases and the effects of medical product that are consistent across those populations, it strengthens the reliability of our evidence. And most of the healthcare questions we're asking are global questions that require global answers. So the notion that we can think internationally and think across our geographies is fundamental to how we can actually generate evidence that will scale. Another desired attribute about reliable evidence is that it would be robust. That is, that given the same question in similar data, if we were to apply different analytic approaches that still conform to our scientific best practices, that they may yield similar results. We don't want an analysis result to be completely predicated on what specific design consideration that an analyst chose. And by having a wealth of best practices that can be applied consistently and identically to similar questions, we can actually examine the sensitivity of our analysis and hopefully yield consistent results that makes us feel even more confident about what we've seen. And then last but certainly not least, another desired attribute of reliable evidence is that evidence is calibrated. That is, that if we were to apply the same methods to the same data for a question for which we know the answer, then that the result we would generate would be statistically consistent and that it's properly interpreted for what it's intended to mean. Now, the reason I'm starting this presentation by highlighting these desired attributes of reliable evidence is because none of us, not myself or Christian or George, not Mui or Chan or Mark, nobody you're going to hear about by themselves could accomplish all of these elements of reliable evidence. And it's because producing reliable evidence requires a community effort. We need a community of researchers working together to identify exactly what are those specific research questions that we need to answer together. We need a community to come together to build a data network that uses the same consistent community data standards if we're going to be able to evaluate replicability in similar populations and generalizability across different populations. We need a community to come together to build open source tools that allow us to not only reproducibly execute analyses, but also to evaluate the robustness of our analytic assumptions. We need a community to agree on shared best practices for how to conduct responsible analysis and for how to interpret the results of those analyses in an appropriate way. And we need a community that's willing to come together towards a shared mission to share evidence once we determine that it's reliable, so that patients' lives can be improved through the evidence that we share. This community effort is what inspires me to be part of this OHDSI community, and what I hope will inspire all of you to continue on the journey with all of us in the OHDSI community as we think about how to go on this journey from data to evidence together to make that evidence reliable and something that we can be proud of not only in the Asia-Pacific region, but all the way around the world. Given that we have this need for a community effort, let's talk about exactly how that works with our data network. To do that, I'm going to turn it over to my friend Christian Reich.
Thank you, Patrick. Welcome everybody who's listening to us.
Christian, you're on mute.
Still on mute. I don't know.
Now you're good.
So, thank you. I'm going to say it again. Thank you, Patrick, and welcome everybody. And I'm going to quickly talk about the network that we have built in the last 5 years. Next slide, please. This is it. Every one of these red tags constitutes a collaborator. Okay, so this is OHDSI. It's a large community. How does that work? I mean, where are these people? And do they really exist? And how can they collaborate? I'm going to show you. So where are they? They're in a bunch of places. Foremost, we have a open forum. Forum means that's where people talk, discuss, debate, have ideas, jump on ideas, dismiss ideas. A very, very active public place where people have these conversations. As you can see, there are 4,000 users who post a lot of information, opinion, and debate. There are community meetings every Tuesday. There's a meeting for the whole world, and then there are local meetings. There are work groups who focus on specific activities. There are regional chapters. One of them is the one that we are just having a symposium for all over the world, who focus a little bit on their own local needs in their own local languages, but they're still part of the overall global OHDSI family. There are tutorials where the community teaches people, other members of the community. Okay, there are the symposiums that are held in the various geographies. Last one we had was the general one in October, and now this one. There is active Twitter and LinkedIn activities to show people in the rest of the world what we are doing. And now we also have a Microsoft Teams environment globally, which we are at the moment all inside. So all these people, what do? They do the kind of research that Patrick alluded to, evidence generation, and George is going to show you examples. They do that on the basis of actual patient data. We have over 200 entries in the network. 166 are active data providing or data hosting network members. There are probably more. We don't know them all. There are people who don't declare them, who haven't declared themselves. They are in 23 different countries, and there is a rich corpus of almost 600 million distinct patients, roughly counted, spread over the various continents, and that amounts to almost 3 billion records across the whole. So 600 million distinct patients and records 2.7 billion, which of course means some of the patients repeat themselves in different data assets, so they are not unique. Next, how does it work? It works on the basis of an harmonized data representation, a format, and content, the vocabularies. This is the standard format. It's called the OMOP Common Data Model. Every data asset that is participating in the OHDSI community is in this format, which is very powerful because they all look the same. They don't contain the same data, but they all look the same. And anybody who wishes to generate evidence knows where to go. They know that the condition occurrence tables contains the conditions. They know that the person table in the upper left corner contains the demographics, and so on. That's the format. And then there is the representation. What do I call things? On the next slide. That's called the standardized vocabularies, which means, what does it do? It takes the various representations and normalizes them to a standard representation, such that a heart attack is called the same thing in the United States, in the UK, in Germany, in Korea, and in China. And so is, a mole on the skin, and so is an ibuprofen tablet, 160 milligram. They are all called the same way. This is very powerful because what it does is it allows truly remote or federated network research. I can query your database even though I will never be able to see the data. I will never get access to the data. That means it's a lot. You need a lot of vocabularies to cover here, because in the different countries they all use different ways to call things, and we need to support them. So OHDSI puts an enormous effort in supporting in the various countries the various domains, as we call them, or aspects of clinical data. That has grown a lot over time. So we have almost 10 million concepts now that represent everything that's necessary in medicine and to generate this kind of evidence. Next. For example, some of them are used in Asian countries and Pacific countries. So for example, there's an ICD-10 Chinese version with 34,000 codes, which are all mapped to the standard, in this case, SNOMED. There is a Korean version of ICD, which is mapped. Same is true for the drug vocabularies, for the procedure vocabularies, for the measurement vocabularies. OHDSI provides support for these various representations in these countries, and there's going to be there's more to come. And if you have a need, then please engage in the community and help build this this very rich resource, because again, it allows us to ask the same questions in the entire world. Next, which is how it works. So if you look at it, this is the secret sauce of it, right? The original data all look different. They have different database systems, they have different representations, different languages. They get transformed to the common data model, and then they look the same. And if they look the same, I can apply standardized, reproducible analytics, just like Patrick declared at the beginning. And we use R and we use SQL for doing that. And it allows us to do this in an open fashion, so we can show everybody in the world how these pieces of evidence are generated. There's no black box. Everything is online and can be tested and can be checked and can be improved. And that only works because the data is standardized. One more, some more. Is there one more slide? That's right. So, and what that means is we can be transparent. It also means we want everybody who participates to be transparent as well, which means that our analytical pipeline is in the public, and the research is in the public, and the results are in the public. And this is the spirit that we want to pursue this. So we have common documentation, common quality, common protocols, common analytics, common studies, and common interactive results. A public and transparent representation of all these things makes them trustworthy. People trust it if they are in the public, visible, and can be checked and can utilized by everybody. Next. Thanks. That's how the network works. And now George is going to continue and talk to you about what we have achieved and what we've done so far and what it looks like.
Very good. Thank you, Christian. And this is George Hripcsak of Columbia University. It's an honor to be here, and I congratulate the organizers who have put in all this work to put together this great program. We can go to the next one, Patrick. I'm going to give some examples of what I think are important evidence that we've generated. And what you'll notice in my presentation is that Asia-Pacific played either a key role or a leadership role in everything I'm going to be showing. When COVID appeared, OHDSI went into action and had a study-a-thon in March, 88 hours long. I remember those 88 hours because there was no hour of rest. And in fact, for the next 2 weeks, I remember going to meetings around the clock, including 3 a.m. because of our Asia-Pacific colleagues' leadership on that side. Now go forward. One thing we had to do different for COVID, before our databases could be a year or two old as they were assembled in various ways. With COVID, we needed data immediately. So we sprung into action there, working with data partners, pulling that together. We ended up now today with over 1.6 million patients with COVID in our federated database. I think that's more than anyone, certainly more than anyone that's actually generating evidence. And you'll notice here from South Korea being among the first that had significant patients in the OHDSI network. Next slide. And so I'll give you examples from our 3 areas that we normally generate evidence. The first is characterization. So we characterized this disease. What we did differently from those who came before us was going around the world in different kinds of practices. We showed, like everybody else, that COVID is in older people and sicker people, but we also showed that if you compare it to influenza, it actually affected younger people and healthier people, so in some ways was a greater health risk to the world. So that's something that we published early on the archive and then put it into Nature Communications where it's currently published. Next. And this is a visualization of how COVID is affecting different areas of the body, different systems by condition or diagnosis and by medication or drug, and the consistency between the databases. Next. Now, everything we generate goes onto the internet. There you see data.ohdssi.org, where we immediately put our results for you to browse, and you can find our newest studies on that website. Next thing we do is write a paper and put it on the archive, 5 of them shown there, characterizing COVID in different ways: pregnancy, obesity, pediatric, drug utilization, and so on. Next slide. Now going from characterization, we can next move to prediction. This is cover COVID estimated risk. So this is our predictive model. There are many predictive models for COVID complications coming out. What distinguished ours was that it was validated around the world in different practice types. There, shown on the left, is a kind of a graphical view of our predictive model. Next slide. And then we created an interactive website for people to go on and provide live risk scores. Then we noted that the health minister of Catalonia, Spain, explicitly in their report mentioned cover, our system, as one of the indicators they'll use to measure the impact of a given outbreak. Next slide. In addition, an enterprising high school student connected it to Alexa, so you could have just a verbal connection to our predictor, and she presented it wonderfully at our recent symposium. Next slide. One of the most important estimation studies we did was on hydroxychloroquine and azithromycin, showing the risk of those 2 drugs when put together. That was used by the European Medicines Agency to decide to withdraw approval for hydroxychloroquine for COVID. And it was also given to the FDA, but EMA was the one that told us that they used it. So it's actually being put into practice as well as publication, Lancet Rheumatology. Next slide. Another area was hypertension drugs were being stopped by patients because they were afraid that these angiotensin-related drugs might worsen the severity of COVID because it was postulated it was possible. We ran an early study looking at that, put it on the archive, where the EMA noted that our study, Morales' study, for its approach, of its reproducible approach, what Patrick described at the beginning of this talk, that we're kind of the gold standard for that. And it was now accepted for publication in Lancet Digital Health, showing that those patients should not stop those drugs. Next slide. Then not COVID, but our Legend initiative, which started before COVID, in this case, the hypertension one, showing publication in Lancet and JAMA Internal Medicine, indicating that it's slightly different than you might have thought, that diuretics were doing better than ACE inhibitors being the most commonly prescribed drug, and that the traditional hydrochlorothiazide does better than chlorthalidone. You'll notice Asia University and University of South Australia noted there, again, Asia-Pacific being an important part of our Legend studies. And then my final example, next slide. Oh, no, first, before I do that, just pointing out our Legend approach that our, kind of our pinnacle of reproducibility is published in JAMA, the top informatics journal. On the left, showing our 10 principles. On the right, showing our validation that the evidence we generate is indistinguishable from evidence previously generated by randomized clinical trials. Next slide. And finally, this study, which was led by Asia Pacific, Chan Yu, on anticoagulation, but it's our first study that we published in JAMA, so we're very proud of that publication too. So let's go on to our next slide. Here we see our agenda. It's a great agenda and a great 2 days, and again, I want to thank and congratulate the leadership group that put that together. And next. And then our collaborator showcase. I want to thank and congratulate the 7 projects that were put forward and presented. I hope you'll go and attend those sessions and also ask questions. So it's a great symposium. Look forward to it, and I hand it back to Patrick.